Hello class, this is Mrs. Putman and I'm going to be doing the assessment of the newborn. You can follow along in this little page that I've made, and it's to help you to pass your competency. So I'm going to go through this. You can follow along or review later. Anyway, so when we assess our newborn, we want to first just take a look at that baby and see if he's okay. I love it when they're sleeping because that makes it a little bit easier to start and listen to their heart and lungs. But before I do anything, I need to do the number one thing they taught you in basics, which is hand washing. So, scrub in, scrub out. Okay, let that dry. Took a little too much. Okay, so because my baby is sleeping and he's had his first bath, I feel very comfortable touching him without any gloves on. And since he's so quiet right now, I'm going to listen to his heart rate and his respiratory rate. We want to listen to the heart rate for 1 minute. You want to use the bell of your stethoscope, and you want to listen or watch the respiratory system. Each nurse is going to do that a little differently. So the heart rate should be between 120 to 160 on the average. And it's really fast. It sounds like a staccato. So you have to practice listening to those to get good. And the heart rate is kind of funny because it's 30, the rate is 30 to 60. And that kind of moves, and they have those little spells of apnea, and you're like, come on baby, breathe. And then it starts breathing really fast, and then it slows down again. All right, so I'm just gonna demo for competency what it kind of looks like. And so I haven't checked my badge yet, but I did ask mom for permission to examine the baby or take the baby on her and her husband on a tour of the baby, because babies are unique. So I'm going to be really gentle, and I'm going to keep the baby warm. That's essential. And I'm going to listen to the baby's heart rate for a minute and tick, tick, tick. Then I'm going to listen to the baby's lungs, and I might start this. At this point, this baby will start crying, and I will know that the lungs are very, very good. Okay, and since I'm right here, and if the baby has not made any meconium yet, which is baby poop, then I will listen to the bowel sounds as well, and hopefully I'm hearing things. And then I'm gonna start from the head to toe, and remember, I have to keep this baby warm. Okay, so the very first thing I like to do is I want to check the baby's head, and at the very big top of the head there's an anterior fontanelle. I'm going to go across down here to the sagittal suture, and I'm going to find the posterior fontanelle. Sometimes this is hard to find because the baby has the molding. Then I'm going to look at the baby's head, see if it has a caput or a cephalohematoma. A caput is from too much molding, and it goes across the entire head like a baseball cap. And a cephalohematoma is bruising from too much pressure during labor. So while I'm here, I'm going to look at baby, and I'm going to check that his eyes and his ears are symmetrical. And that's one way we check to make sure that the baby doesn't have Down syndrome. I'm also going to look here at the baby's ear, and I'm going to try to pull it down. It's not going to on this baby doll. And I'm just going to make sure that there's no marks or anything on the back. That just the age of the baby is somewhat noted on the ear, but I'm going to get to gestational age in just a moment. I'm going to check that there are 2 eyes here. Now, if we were under a warmer, these baby would be like at the cop car looking at the lights. What do we do if we get pulled over at night? We would close our eyes too. So if you dim the lights, you can most likely check to see that there are 2 eyes there. The next thing we want to check is for coronal atresia. Kind of a nice big word. And so you want to just push your baby's lips closed, mouth closed. Push on one nares, and you'll hear a little snort out of the other one. And then you're going to do that on the other side, and you're going to check that. And then you're going to know that the baby's nares are both working. It's a pretty gross check, meaning that it's not the most accurate check there is. Okay, then I'm going to put my baby's head covering back on because I have to worry about the heat. Okay, I'm going to check here now his neck, and I'm just checking to see that there's no fremitus and that there's nothing there. Then I'm going to start unwrapping the baby a little bit again. And I'm going to move his arms so I know that his clavicle should be okay. And I'm also going to do a reflex here. And this is one of our first reflexes. And it's called the Morrow reflex. I'm just going to gently lift the baby up and he's going to startle. Okay, an exaggerated startle response. Sometimes you see this when you come by their crib and you hit the crib with your hip, you'll see this startle response. That is the Morrow response. That is unique to newborns. Okay, so then another reflex that I'm going to do is I'm going to do the Palmer reflex, and that's when I'm going to take the baby's hand. I'm going to take my hand, put my fingers here, and make it's going to immediately grasp just like this. You want to do this at the same time if possible because it just means that the neurological system is more intact. And parents love to do this because they think their mom, oh, my baby loves me, look at he's holding on to me, and they're just so adorable. Okay, so that's 2 reflexes so far. We didn't talk about the rooting reflex and the sucking reflex. The rooting reflex is when I'm going to go like this and the baby's going to turn his head. Okay, that doesn't always happen. And then I can't really demonstrate the sucking reflex, but I would wear a glove for this. And there, I'm going to go ahead, I'm going to put my finger inside the top of this baby's mouth, and I'm going to swish around both sides, just check that there's no teeth and that the mouth palate is firm, and then I'll let the baby suck on my finger, and then I know I have a good sucking reflex. And that is vital to the baby's life, because if they can't suck, they can't eat. So that's a really important reflex. So we've done the Morrow reflex, we've done rooting, we've done sucking, and we've done Palmer. Okay, so now I'm just going to bring this back up here. I'm going to look, I want to check my baby. Everything looks symmetrical, only 2 nipples here. I don't see any birthmarks. Here's the baby's umbilical cord, and you'll hopefully get to see this earlier, and you'll be able to see the baby's vessels. But this baby's has already finished. So we have 3 vessels on our umbilical cord, and we call it AVA, artery, vein, artery. And those are really exciting to see in real life because you can see the anatomy and physiology happening. Okay, so before I undo the diaper, I'm going to go ahead and do these other reflexes on this side and check the baby's legs. I still haven't seen any birthmarks or any skin problems. So I'm going to go ahead, and this is the plantar reflex, and it's the same as the Babinski. I'm just going to press my finger right here, and again, like monkey toes, or just the baby's just really excited. I'm also going to do the Babinski reflex, and I'm just going to push here, and my legs are going to, my feet, excuse me, my baby's toes are going to flare out. And this is very unique to a newborn. Because of that, we did that, had that reflex. That would mean we had a stroke. So we don't want to see that in our adult population. That's another way that we know that this baby's brain is growing, and it's really important to, spoil your baby a little bit. The other thing on this foot, you can see creases and marks. So when the baby has 2/3 of his hand or his foot with creases, that's a good gestational age assessment. So that this baby looks full term. Okay, so then the next thing we're going to do while we're here is, and now this is a boy baby, so you need to be very careful because you don't want an extra shower. So with that being said, I would now wear gloves because I'm going to be touching maybe pee or poo, and I don't want any wet things on me that aren't mine. So I sometimes will shield because as the oh, it's a baby girl. Don't have to worry. Anyways, I want to check that her labia are closed, which they are. That's another sign of gestational age. And she doesn't have anything in her diaper, so lucky us. I'm going to go ahead and do Ortilli's sign, and which is also just checking for congenital hip. And this you're just going to pull out and then, and pull down. It's much easier on a real baby. And that's checking for congenital hip dysplasia, and very important disease to check for. If you hear a click or a clunk, you want to report that to your physician or pediatrician while you're there. Okay, so now I've got my baby. I've listened to her heart, her lungs, checked everything out. Gestationally, she's checking out about 40 weeks because she looks so good. I'm going to go ahead And I'm going to turn her over onto her tummy. And then remember, when they're in bed at home, we want them to what? Sleep on their backs. Back to sleep is our preferred position for sleeping to prevent SIDS. And I'm going to go ahead and go down her spine and just take a look. And everything looks to be in shape. And then I'm going to look at her dimples. And I don't see a pilonidal dimple or any cyst or anything. She's got beautiful skin. I don't see any Mongolian spots, which are not uncommon in most of our population. And then I'm going to go ahead, I'm just going to take the diaper off for a second. And I'm going to pull down her legs so that they're both extreme. And if you look, you want to make sure that all of the creases line up. And that's another sign that the baby's hips are in the right order. Okay, so she looks good from here. Everything looks lovely. I'm going to turn her over. And again, when I do that congenital hip, I also pull down both of the legs to look and make sure that all those creases are in the same exact space. Okay, so we've done our reflexes. I want to maintain temperature, remember, so I should immediately get her back and wrapped up. I've done a good skin assessment, very important. The most common skin birthmark you will see is Mongolian spots. And then if I need to administer injections and medications to her, I'm going to do eye medication is going to be erythromycin eye ointment. And I want to do that from the inner canthus to the outer canthus. I tend to kind of put the lights down low and just put it on top of the eye and know that the baby's eyes are going to go up. I kind of do a cake boss, and I know that that medicine will be there, and that was a trick that one of my nurse friends taught me. And then when I'm going to be giving the injections into the outer thigh there, I'm going to be giving both hepatitis B vaccination, the first one of series, and vitamin K. The patients have to consent to the hepatitis B, but vitamin K and erythromycin eye ointment are standard. So make sure when you go to attempt this that you know the gestational age, the temperature, heart rate, the color. We should talk about the color. So this baby has nice pink cheeks, looks really lovely. Sometimes in that first few hours as they're adapting to extrauterine life, you'll notice that the extremities have a little bit of a bluish hue on the hands and on the feet. That's normal. That's called acrocyanosis. That's part of our APGAR scoring. And let's see, we talked about the fontanelles. We talked about all the reflexes. We should expect to see some vernix on the baby. That's a protective covering. It's kind of white, and that's to protect the baby from all of the fluid. And we'll look for lanugo, which is a little bit of fine hair. You're gonna see that in your 36, 37 week babies. 50% of our babies are gonna have some erythema toxicum, and those are like red blotchy spots, and it might look like the baby has a little bit of baby acne. I'm just trying to make sure I hit everything. We don't do blood pressure, but we do height and weight measurements at birth and daily. So how you're gonna get and temperature. Silly me, I forgot temperature. So temperatures, I get those after I get my heart rate and respiratory rate. And so I'm gonna go ahead and I'm gonna put it on, and I'm gonna put this here. Now, if I put the thermometer like this, I'm gonna get the room temperature, and that's gonna be significantly cooler than 97.7. So I wanna make sure that when I take that baby's temperature, I'm right here on her skin, and I wanna kind of hold it close so that I get an accurate temperature, and then I'll hear the beep, and lo and behold, she's a beautiful 98.2, so that's very good. I haven't chilled her. I would do that early because you don't want to stress the baby. And what was this? And we talked about watching the respiratory rate and listening to it. That's gonna just take some practice. And we talked about medications. Let's see, what other questions do you have? Oh, measuring. That's what you forgot. So usually I put the baby in under the warmer. I'll take their hat off, and I'll put them up to the very edge of the warmer. And since the baby's under the warmer, I don't really need to worry about keeping her warm right now since we changed locations. And I'm gonna go ahead and I'm gonna pull her leg down, and with my pen, I'm gonna mark a little spot on the sheet. Then I'm going to move her over, and I'm going to go ahead, and this is a typical measuring tape, one use only. And if you see here, it has a 2 centimeters. I usually just put that back, and I go all the way there. And you're going to record it in both inches and centimeters because facilities and physicians like it differently. And then I'm going to pull this down, and lo and behold, my baby is 20 inches long. So that's good. I weighed her on the scale naked when lifted, and there's a whole process. You'll have to see that in the clinical setting. And then I want to measure this baby's head circumference. Remember, the head circumference should always be the biggest circumference of anything that you measure on this baby because it had to go through the vaginal canal to get out. So this baby's head is 15 inches. And then I look on that, what is 15 inches? I can mark it, I'll turn it over. It's a big head. That's 38 centimeters. Then depending on which facility you're at, you will measure the chest, and that's going to go right over the nipple area, and you want to hold that firm, and that's 13 inches. It'll probably be in real life about an inch smaller, and then some have you do an abdominal, and that's going to go right here, and that should be, and that's 13 as well. So this baby would have, if truly a baby would have made it. You don't want to do this because this is a really bad thing because these babies will get paper cuts. So you just want to roll and make sure that you don't get a baby cut. Always make sure that you wrap your baby. And now that you want to make sure that the band, this is Diana Hospital, and how are you doing, Mr. or Mrs. Hospital? Okay, good. Well, now that you've had this tour and all these unique things about your baby, do you have any questions for me? You always want to make sure that they have any questions. Then you want to wrap them up, and this is a really great time for the mom. You can ask her if she wants to breastfeed because the baby might be a little fussed. And so we can wrap her and ask her how she wants to proceed. So the baby wrap is kind of a fun little thing to learn how to do. Always hold your baby so that you have good control of the baby and the baby is not going to fall. A lot of people put their hands like this, so there's no way, even if this baby were to fall, it wouldn't fall out because I have good control. And some people hold on to the leg and the hand always, and this is probably the best and safest method to hold somebody else's baby because you have control in 2 different spots. Okay, so let me get my little blanket ready here so I can go ahead and wrap my baby and make a little fold. Not perfect. Nurse Julie makes a great baby fold, and we call this the snuggle wrap. You can go under or over, and then you're going to pull her in. Okay, and that's it. That's a wrap. That's our baby assessment.